Thank you so much. And I'll spend about 35, 40 odd minutes on the subject. And I was also talking to the chairpersons that perhaps if we have a little time, I will, we can probably do questions at the end of each lecture as well. Am I audible?
No.
So when we talk about interstitial lung diseases and airway diseases as well, perhaps nothing is more important than the quality of the study. This is extremely critical. The reason is that very often we have images like these, and on these kind of images we often land up saying that there is ground glass attenuation. This allows us to then make a diagnosis perhaps of hypersensitivity pneumonitis, but if you see carefully, these images are blurred. And if the image is taken carefully, this is what you would get. There is no ground glass attenuation here. Perhaps at the most there is a little bit of increased lucency, maybe there's some small airways disease, but this is the kind of image that we do not want. Having said that, a large number of imaging centers will produce images like this, perhaps because there is lack of time, perhaps we're not able to train our patients into doing something really, really simple, and that is breath hold. Obtaining good quality images for the lungs is not rocket science. It does not require a 320 or a 256 slice scanner or a flash scanner. You can get great quality images on a conventional single slice scanner as well, because what we require is not scanner dependent, but is really dependent upon patient training. So we need extremely good breath hold, and the technologists or the nurses or the doctors, whoever is actually going to instruct the patient on breath hold, needs to actually explain to the patient in his or her language, something that the patient understands, so that the patient can take a deep breath and hold that breath. This is what we require. Now, it's not just enough to have breath hold. We require the images to be in end inspiration. If we take an image in end expiration, I just realized that we have an issue on this projector. I would suggest that, especially for those at the back, do look at the LED screens because they project the HRCTs much better. There's a little issue with contrast and brightness on the center screen, and this usually comes out with lung imaging a little more than it does with others, but I think we'll get through this. Nevertheless, when we see a gradient that goes from non-dependent to dependent, as we're seeing here, we see an increasing whiteness that goes from non-dependent to dependent. This is an expiratory image. And again, there is a chance that if we're not very sure of our images, we might say that there is ground glass attenuation in the dependent segment. Same patient, virtually at the same time, same level. This is the inspiratory image. This is the kind of image that we require that would then allow us to say whether this is normal or abnormal. And I'll run through this again. That's the expiratory image, and the way to make that out is to see that there is increasing whiteness as we go from non-dependent to dependent, as against this being the inspiratory image that we require. So we need images in full inspiration, and we need them with suspended respiration. Another way to differentiate inspiratory from expiratory images is to look at the trachea. When the trachea is oval and round, that's an inspiratory image. When we see a posterior convexity, as we're seeing here, then this is an expiratory image. And therefore, when we're scanning through the images, either on the workstation or films, it's a good idea to take a look at the trachea and make sure that we're dealing with inspiratory images. By definition, an HRCT image is 1 millimeter or thinner. Every CT scanner manufactured in the last 10 years would allow us to do that, and we need to use high-resolution algorithms, which are very standard. So as I said, none of this is really scanner-dependent. What we need is patient training, and that's what then gives us the quality of images required to make accurate diagnoses. In some situations, we require prone imaging. This is typically in patients with suspected or known connective tissue disease where we're screening for the presence of interstitial lung disease. And often we see these subtle areas of reticular opacities that are only in the dependent portion. And the question is, are these real or are these gravity-dependent densities? So if we flip the patient over and then wait for about 3 to 4 minutes, if they were gravity-dependent densities, they would disappear. If they persist, as they do in this study, then we know that this is real and this represents early interstitial lung disease. If these same reticular opacities were to be seen in the non-dependent portion, we wouldn't require prone imaging because that is the correlate of a prone image. It's only when we have dependent lesions only. That's the time that we would require to do prone imaging. As against another patient here who has these dependent densities, they completely disappear on the prone image, and therefore we know that these are gravity-dependent densities and do not imply the presence of interstitial lung disease. The lung reacts to insult in a finite number of ways, right? So we know that consolidation, which is increased opacity with air bronchograms, can occur with a lobar pneumonia, with a hematoma, it can occur with a bronchoalveolar carcinoma, with lymphoma, with organizing pneumonia. It's the same pattern. The same consolidation can mean different things depending upon whether the patient is presenting with leukocytosis and fever, or whether the patient has one bout of hemoptysis and is otherwise asymptomatic, or has had a blow to the chest. And in chest imaging, and perhaps this is true of all radiology, but more so with the lungs and the chest, the clinical story is extremely important because you have a few patterns, a large number of diseases, and overlaps. And if we don't have a lot of time, if we don't have a lot of people to give us a lot of history, and obviously our referring doctors refuse to give us histories all the time, then the least we could do is have a short form that captures whether the patient is a smoker or not, and that's because some interstitial lung diseases only occur in smokers and some diseases never occur in smokers. So it's very, very critical to know whether the patient is a smoker or not. The other thing we would need to know is whether the patient is HIV positive, because again there are certain specific ILDs that occur in smokers, in seropositive or retroviral positive patients. And to capture this, perhaps the only question we need to ask the patient is, are you suffering from a systemic disease, or do you have a history of a prior systemic disease? And that would cover everything from connective tissue diseases to cardiac failure, renal failure, liver failure, all of the other things that we would need to know to allow us to make a definitive diagnosis. This is one way of making sense of the 250 to 300 conditions that present as interstitial lung diseases. Of the 250, 300, 90% fall into the exposure related. So either they are drug related or they are occupational related. Then we have all the connective tissue disease stuff. Sarcoid merits its own little branch. We have the idiopathic ones, and those are the ones that create the confusion because, again, all the sadistic and masochistic chest physicians and radiologists love having mnemonics that they can then spout and look very, very intelligent about. And then you have all of these other ones that are long names simply because we don't really understand much about them. But we can make some sense out of this. When we look at interstitial lung diseases, depending upon the practice, there are not more than about 12 to 15 conditions that would form 90 to 95% of the diseases that we see. Typically, in a university or a hospital practice, idiopathic pulmonary fibrosis would be about 50% of the practice. Connective tissue disease-related interstitial lung disease would be another 20–30%, and then you would have hypersensitivity pneumonitis and sarcoidosis forming the other 10 to 15%, and then the rest. In a private practice setup, perhaps depending on the area that we are, connective tissue disease related ILD, hypersensitivity pneumonitis, and sarcoidosis would be the common ones, followed by idiopathic pulmonary fibrosis, and then the rest. So while there is this huge number of diseases and a large number of names, you can actually boil this down or condense this down to a few conditions that, if we know how to diagnose, would take care of 80 to 90% of the ILDs that we see in practice. The other 10% you have to leave to experts like us, but we never get it right anyway, so it doesn't make any difference. Neither do the histopathologists for that matter. So it's perfectly all right. But let's look at the common ones. One of the commonest conditions, as I said, is idiopathic pulmonary fibrosis. It's pretty much a deadly condition with a 5-year survival rate of 20%, and it's worse than having stage 1A lung cancer or a early form of breast cancer. The way to diagnose IPF is to be able to pick up honeycombing. And if we can figure out what honeycombing is and be able to diagnose this all the time, it pretty much takes the pain out of interstitial lung disease imaging. So honeycombing is layered cysts that go from the periphery to the hilum in the basal region, stacked one upon the other. Right? So if we can pick this up, this changes everything. Now there are 3 other conditions that present as cystic diseases or as holes within the lungs. We have this, where you have branching cystic areas going from the hilum to the periphery, and this is typically bronchiectasis. We have cysts without walls with a centrilobular distribution. You can see them much, don't see them well on either of them, but nevertheless, cysts with walls that are present around the vessels. This occurs with centrilobular emphysema. And we have cysts with walls that are randomly distributed throughout the lung parenchyma. This is what we get with cystic lung disease, of which there are 2, lymphangioliomyomatosis or LAM and histiocytosis X. Now you've been seeing honeycombing on the left-hand side, layered cysts stacked one upon the other from the periphery to the hilum. Very, very different from bronchiectasis, cystic lung disease, and centrilobular emphysema. Another way to look at them is to say you have cysts without walls, and that's centrilobular emphysema, and cysts with walls, that would be bronchiectasis, honeycombing, and cystic lung disease. So if we are confident of picking up honeycombing, then we can pretty much make a diagnosis of a usual interstitial pneumonia pattern or the UIP pattern. Couple of additional things that we require are a subpleural basal predominance and the absence of anything else. So there shouldn't be any ground glass, no nodules, nothing else. So pure honeycombing, basal predominance tells us that this is a UIP pattern. Now, what the ARS and ETS did in 2013, April last year, was wonderful. It completely changed the way we look at UIP, IPF. And they said, if you have a UIP pattern on an HRCT with no identifiable cause, then that's IPF. And you don't need to do a lung biopsy. You don't need to do a bronchoscopy. You don't need to do anything. One of the few times that a radiologic investigation gives us histopathology pretty much directly, and we don't need to prove the diagnosis on histopath. So honeycombing with a basal predominance with nothing else equals to a usual interstitial pneumonia pattern or the UIP pattern. And in the absence of an identifiable cause, what are the identifiable causes of a UIP pattern? You can have smoking, familial, connective tissue disease, asbestosis. All of these also present with UIP patterns. But if there is no cause, if we do not find an etiology, then it's idiopathic. So it becomes idiopathic pulmonary fibrosis, right? So honeycombing equals to UIP pattern. No etiology makes it idiopathic pulmonary fibrosis or IPF. When we see patients with IPF, we follow them up radiologically virtually every year. And when we do that and we put all those scans together and we're scrolling on the workstation after syncing them, we also look for superimposed complications. The incidence of malignancy in IPF patients is 13 times that of the normal population, and they also suffer from superadded infection. So when we see a focal opacity in a patient who otherwise has IPF, we would need to figure out whether this is tuberculosis or malignancy and typically do a CT-guided or bronchoscopy-guided biopsy. This patient had tuberculosis. Luckily, though it doesn't really matter, because if the 5-year survival rate is less than 20%, all that this does is hastens death a little more. And this patient had consolidation with ground glass attenuation that eventually turned out to be bronchoalveolar carcinoma. Another entity that is very, very interesting and behaves a little differently from standard IPF is a combination of emphysema and fibrosis. This is seen only in smokers, so we get centrilobular emphysema with perhaps paraseptal changes in the upper lobes. We get an IPF pattern or a UIP pattern in the lower lobes. And these patients have a slightly better prognosis than just the idiopathic pulmonary fibrosis. This is no longer idiopathic. This is smoking-related combined pulmonary fibrosis and emphysema. And they're also very, very interesting with their pulmonary function test because they actually have volumes that are maintained rather than the low volumes and the diffusion problems that you have with IPF. But nevertheless, it's not a good thing to have, but it's a shade better than IPF. Spend a couple of minutes then on the basic anatomy and pathophysiology of interstitial lung diseases. We have an anatomic unit called the secondary pulmonary lobule, which you can see here as a hexagon lined by these interlobular septae. In the center is a vessel which is white. Next to it would be a feeding bronchus that then divides into 4 or 5 terminal bronchioles, each of which divides into respiratory bronchioles, then alveolar ducts and sacs. When we see the secondary pulmonary lobule, it means that this is abnormal. Either there is septal thickening or there is some other reticular stuff that is happening. So if you see this cartoon here, you have the normal secondary pulmonary lobule with the bronchus or the vessel within. All the idiopathic interstitial pneumonias typically begin within the secondary pulmonary lobule. We call this intralobular interstitial thickening, and then as time passes by, you get fibrosis, honeycombing, etc. In fact, in a patient with a UIP pattern, you can see different ages of disease. So here, this seems to be normal because we don't see any gray stuff within the secondary pulmonary lobule. Here we see some gray stuff which implies an interstitial process, and here we have honeycombing which implies destruction of the alveoli and pretty much an end-stage process. We then move on to another entity that is equally important, and that is a reticular process that looks like a UIP pattern, but there is no honeycombing. So you've got areas of intralobular, interstitial, and septal thickening. It all looks quite bad, but there are no cystic areas. There's no honeycombing at all. And when we see this, we're pretty much dealing with the NSIP pattern or the non-specific interstitial pneumonia with fibrosis pattern. The only caveat here is age. If we see what looks like an NSIP pattern in a 75 or an 80-year-old, chances are that that's early IPF without honeycombing. But if we see this in a 50 or a 55 or a 40 or a 45-year-old patient, almost always this means that there is underlying connective tissue disease or collagen vascular disease. It is now very well known that the lung can be the first organ involved with connective tissue disease. Our rheumatologists, unfortunately, still do not get it or still not willing to get it because I mean, if you believe that the eye, the skin, the hair, the bones and joints can be the primary or the first organs involved in a connective tissue disease, why not the lungs? And we now know that we have patients who present with NSIP patterns who do not have rheumatologic diseases at presentation, but about 5 years later, 10 years later sometimes, will present with that connective tissue disease. So the younger the patient, when we see an NSIP pattern, it almost always implies an underlying connective tissue disease. Why is this important? This is important because the 10-year survival rate of an NSIP pattern patient is 70%. A UIP pattern, if it's IPF, the 5-year survival rate is 20%. If there's an etiology, then the 5-year survival rate is about 50–60%. But with an NSIP pattern, the 10-year survival rate is 70%. UIP patterns cannot regress. They can be controlled at best, but they will eventually progress. NSIP patterns can regress, and that's the beauty of the pathology. And you can see a patient here of rheumatoid arthritis who has very, very subtle disease. A year later, the disease is pretty much unrecognizable. And you can see that in the upper lobes as well. If I didn't know that the patient had presented with subtle NSIP pattern, I would have probably called the scan normal. And that's what can happen with the NSIP pattern. So that's 70% of all ILDs, UIP, IPF, and NSIP. And then we move on to the other conditions. Septal thickening is thickening of the interlobular septae, and we saw that as one of the ways in which you can then identify the secondary pulmonary lobules. The septae contain connective tissue, lymphatics, and veins, and therefore you can get septal thickening with interstitial lung diseases, with fluid, with lymph, and with cells. Typically, if we get septal thickening in the upper lobes and we get bilateral pleural effusions, this tells us that the patient has volume overload, and this typically happens with left-sided failure. Another caveat or rule to remember is that pleural effusions and interstitial lung diseases do not go together. There is virtually no interstitial lung disease that presents with effusion or has pleural effusion as part of the spectrum of findings. And therefore, whenever we see effusion, it means that the other findings do not represent interstitial lung disease, or if the patient has interstitial lung disease, there is a superimposed complication that could either be failure or a superimposed infection or malignancy. So effusion, interstitial lung diseases, that's a no-no. That doesn't happen together. So here is a patient who has left-sided failure. 24 hours later, I was able to get this patient back in because the referring doctor was a friend. The patient was given diuretics, and in 24 hours, the effusions have disappeared and the septal thickening has gone as well. Another cause of septal thickening would be any lesion that obstructs the veins. Now, this happens with lung cancer. It happens with mediastinal fibrosis, which is quite common in India as part of a post-tuberculous phenomenon. And you can see that the inferior pulmonary vein is gone, and then you have back pressure venous congestion that presents with septal thickening. And then we have one dreaded condition that pretty much tells you that your survival is going to be less than 12 to 16 months, irrespective of the primary that you have. And that is septal thickening with some nodularity, and this represents lymphangitis carcinomatosis. Lymphangitis can be subsegmental, segmental, lobar, one lung, both lungs. And irrespective of how small it is in extent, the moment there is lymphangitis, and I didn't mention this yesterday in my lung cancer talk, even if you're a T1A, N0, M0, if you have lymphangitis, you will be dead in 12 to 16 months. That's pretty much the way in which the statistics work. So it's a bad thing to have. Another rule to remember is that it's virtually unheard of to see lymphangitis in the absence of a known primary in the body. And therefore, for all the radiologists, especially the young ones who would love to make a diagnosis of lymphangitis the first time they see septal thickening in the lungs, do not ever do that. If the patient is not known to have a primary malignancy in the body with breast, lung, stomach, etc., do not make a diagnosis of lymphangitis. The referring doctor will only think you're foolish and it will reduce your credibility in their minds. So that's another rule that we can remember. So these were all the reticular diseases. You have the UIP, IPF, the NSIP, septal thickening. We then move on to a completely different spectrum of conditions. These are the ones that present with parenchymal or alveolar or mixed interstitial alveolar opacities. We have ground glass attenuation, that is a common sign, which is increased opacity in the lungs that does not obscure the vessels, and we have consolidation, which obscures the vessels and then presents with air bronchograms and bronchiolograms. There is one interstitial lung disease that presents with consolidation. We have bilateral subpleural. You can have bilateral peribronchovascular. Usually there is an element of associated ground glass, and as in this case, this looks like a bilateral reverse bat swings, bilateral peripheral mixture of consolidation and ground glass attenuation. These patients present with fever and Velcro ralls on auscultation with a 3 to 4 week history. They're usually sick, require ICU admission, but clinically, again, if anybody tells you that I have a patient who's sick, who has fever and evidence of a subacute onset interstitial lung disease, then either we're dealing with miliary tuberculosis or we're dealing with this condition that is called an organizing pneumonia pattern. I prefer to use the term bronchiolitis obliterans organizing pneumonia or the BOOP pattern. And again, like with the UIP pattern, there are many conditions that can produce an organizing pneumonia pattern. You have connective tissue diseases, lung transplantation, sometimes just bad infections. A lot of these conditions can produce an organizing pneumonia pattern. Drugs like amiodarone, all your chemotherapy drugs, all of these can present with a BOOP pattern. If there is no etiology, then it becomes cryptogenic. So the term COP or COP or cryptogenic organizing pneumonia is to be used only when the BOOP pattern does not have an etiology. They could have as well called it idiopathic organizing pneumonia, but I don't know why they would want to use synonyms of the same word all the time, but nevertheless, whatever. This is another interesting pattern that presents with an organizing pneumonia or a BOOP kind of appearance, and we call this the reverse ground glass. So we have the ground glass in the center with the consolidation at the periphery. Normally you get consolidation in the center and ground glass at the periphery in virtually all the pneumonias, but sometimes it's the other way around. We call it the reverse ground glass halo or the reverse halo sign, and again reasonably pathognomonic of a BOOP pattern. And after treatment you can see how beautifully the lesions regress. Kind of looks like an abstract art painting, and it's very interesting to see some of these. We have differentials of bilateral consolidation or unilateral consolidation with ground glass, and this is a bronchoalveolar carcinoma I showed you the other day. The way to differentiate this is not on imaging, it's the clinical presentation. Organizing pneumonia patterns present, or BOOP patterns or COPs present with fever, Velcro ralls, sick patient who has a bad diffusion capacity. Patients who have bronchoalveolar carcinoma do not have that presentation. They may be breathless, especially if it's bilateral and extensive disease. Otherwise, they may be completely asymptomatic and at best have presented perhaps with a bout of hemoptysis. Ground glass attenuation is increased opacity without obscuration of the underlying vessels. And this can occur because of fluids, cells, anything that can impact the interstitium and the alveolar areas. It's one of the most non-specific signs possible, and the same pattern can mean different things depending upon the presentation. So if this is a 45-year-old lady, subacute onset, living in an area where there are lots and lots of pigeons, we would call this hypersensitivity pneumonitis. If this patient is a smoker, we would call this desquamative interstitial pneumonia, or if it was a little less severe, respiratory bronchiolitis ILD. If this patient presented with a 24-hour history, was sick, needed ICU admission and a ventilator, we would call this acute interstitial pneumonia. And if the patient is HIV positive, the same pattern would be called pneumocystis carinii pneumonia. The same pattern. Nothing changes. It's just the story that changes, and the story completely then changes the diagnosis that we have. Sometimes, though, we have other findings that help us. So within the ground glass attenuation, if we see these confluent, ill-defined centrilobular opacities, then this is very typical of hypersensitivity pneumonitis, right? So if we look inside the ground glass and if we see these nodules, you see them a little more subtly at the periphery here, then this tells us that this is hypersensitivity. Sometimes the ground glass is associated with septal thickening. There are spared areas. This is sometimes called the crazy paving pattern, and this is what we get with pulmonary alveolar proteinosis. And sometimes the ground glass is associated with dense calcification. You can see the pleural ossification, rather, that extends through the septae along the bronchovascular bundles, and this is an entity called alveolar microlithiasis. The ossification is so severe that you actually get an optical illusion here, a mark effect that we often see on X-rays, that actually makes us believe that there is honeycombing at the periphery. This is just an optical illusion. It's not real. It's because of the pleural ossification that we get this black line here between the pleural or the subpleural ossification and the ribs. Very, very interesting condition, quite rare, but seen a lot in Turkey and a little bit in India. Then we have nodules. And the classic nodular interstitial lung disease is this one. It presents with perivascular nodules. We have subpleural nodules, and we have fissural nodules. We may not see all of them at the same time, but the moment we see perivascular nodules, there is only one condition that does this, and this is sarcoidosis. When sarcoidosis presents initially, or when we see the early lung findings, they're always perihilar. You see the major fissure involved just next to the hilum, and we may get just one vessel that shows perivascular beading. On the coronal images, especially if we have a 64-slice scanner or higher, we can get these isotropic images that show the fissural nodules that much better. We should be able to differentiate these nodules from other nodular diseases. Here we have 2 to 3 millimeter size nodules that are randomly distributed throughout the lung parenchyma, extremely well defined. This is what we get with miliary tuberculosis. We've already seen these ill-defined centrilobular nodules. They're very different from the sarcoid nodules. This is what we get with hypersensitivity pneumonitis. And then we have these clustered high-density centrilobular nodules, some of them with what we call a tree and bud appearance, and this is called infectious bronchiolitis and typically seen with tuberculosis. Lastly, we have cystic lung disease. And cystic lung disease essentially presents with cysts with walls that are randomly distributed throughout the lung parenchyma. We have two conditions, histiocytosis X and lymphangiomyomatosis. Histiocytosis X occurs in smokers, lymphangiomyomatosis occurs in women. And so when we see a cystic lung disease like this, and while the textbooks and papers would tell you that there are ways of differentiating one from the other, in real life it's extremely difficult. In real life, if he's a male smoker, it's histiocytosis X. If you're a woman non-smoker, it's lymphangiomyomatosis. If you're a woman smoker, then we're all in serious trouble. So that's the time that you go ahead and biopsy them, because then you don't know if it's the woman, the smoking that's producing histiocytosis X, or the woman who's getting lymphangiomyomatosis, because pretty much occurs only in women. So that's how we differentiate one from the other. And we have one last condition that can present with cysts, and that is lymphocytic interstitial pneumonia. I didn't bring this up earlier because LIP is pretty much impossible to diagnose without histopathology unless the patient presents with Sjogren's syndrome or is HIV positive. In these two situations, if we see a combination of cystic disease, ground glass attenuation, fissural nodules, etc., then we could advance a possibility of LIP. But LIP is something that essentially always requires histopathology. So what we've done in the last about 35 to 40 odd minutes is we've looked at all these 7 idiopathic interstitial pneumonias. We've looked at honeycombing equals the UIP pattern equals IPF in the absence of an etiology, NSIPs that typically occur with connective tissue disease, organizing pneumonias that present with fever, Velcro rulls, and a combination of consolidation and ground glass attenuation, DIP and RBILD that pretty much occur only in smokers. AIP is acute, and LIP occurs with Sjogren's and in patients who are retroviral positive. Hypersensitivity pneumonitis in India is endemic, and the incidence is increasing, and it's actually quite a nice ILD to have because it's completely reversible. Sarcoidosis is reasonably common. The incidence and prevalence would vary from region to region. The pneumoconiosis, and I haven't touched upon silicosis or coal workers because these are region dependent. If you work in an area where there are coal mines, then you see them. Alveolar proteinosis is extremely, extremely rare. The 2 cystic lung diseases, and we've discussed how to differentiate among them, and pulmonary edema, miliary TB, and bronchoalveolar carcinoma are the 3 mimics that we need to know. That's it. 7, 3, 10, 12, 14, and 317 conditions. There's nothing much to it. You just need about 30 years to kind of get to be a little confident. That's it. But nevertheless, this is what 90 to 95% of interstitial lung disease is about. And then you basically need good quality studies and clinical inputs and then understand all these patterns and differentials to get there. Thank you for your attention.